All right. You can see
Hey,
me, guys. Okay?
Kevin, I'm sure everybody knows you, but maybe introduce yourself a little bit.
All right. I'm Kevin Little from Cincinnati Children's Hospital. I've been there for, geez, like 14 years now, so a long time. And I do only pediatric hand, a lot of trauma, a lot of congenital, brachial plexus, and thoracic outlet syndrome is my biggest thing now. For some reason, they just show up on my doorstep. So you take out a lot of ribs in Cincinnati, weirdly enough. But maybe something to talk about at a different date. But we do see a lot of complicated wrist fractures. There's a lot of kids running around doing crazy things in Cincinnati and the surrounding areas. We're the only level 1 children's hospital for 100 miles in any direction. So anybody who does anything crazy comes to us from a long way away. So, but we're going to talk about some of those complicated wrist fractures, kind of go over anatomy of the wrists, some of the epidemiology of these fractures, how do we diagnose them, x-rays, and then do some cases, because I think that's the best way to learn, like what kind of complicated things we're seeing. So we see a lot of kids, but kids fall all the time, and most of the wrist fractures we see are benign, are fairly easy to treat. A simple brace for buckle fractures, non-complicated casting for simple fracture patterns. But if you have more complicated things like ATV or high energy sports injuries, these are becoming more common. You get more adult-like fractures. And I just fixed a 16-year-old with a interarticular wrist fracture dislocation from a car accident. So kids will do crazy things just like adults will. So it's interesting the variability that we see. The wrist is complex, especially more so in the kids with the physis of the distal radius and ulna. There is a large soft tissue envelope, which helps sort of mitigate some of the injury, but also helps aid in healing. So it's good for kids, but as you get older, that soft tissue envelope disappears. But the ligaments are stronger than bone and cartilage. And so you can see occult weird injuries where the ligaments have avulsed a big piece of bone or a small piece of bone, and then we have to fix those to really restore alignment and stability, because the ligaments are important around the wrist, especially the volar ligaments, to help stabilize the wrist in the right spot. So we have to look for those occult injuries. Most of these are occurring at home, people falling off of the stairs, slipping on the ground, outside of the playground. At school, as you get older, some of the monkey bars, other things are happening. And then sports injuries, we see a lot of football, not football, but football injuries, or hand egg, as we call it, because it's really you carrying the ball with your hand and it looks like an egg. But any kind of sports, even with lacrosse or other injuries, like there's just lots of different sports that can cause wrist fractures. So when I see these patients, what I look for is the history. Like, what happened? How did you fall? Do you remember what happened exactly? Any kind of immediate treatment, right? Did you pull on your wrist to make it straight? Did you flop around a while? Anything that makes it look different than it did now, to help understand what the instability pattern is. The neurovascular status, any numbness, tingling, especially the median nerve wrist fractures, but even ulnar nerve. With open injuries, Galeazzi type fractures. And then where does it hurt? Does it hurt radial side, dorsal, volar, everywhere, DRUJ, all these places? Take a fingertip or a pen tip, figure out where it hurts the most. And that helps just sort of guide where your treatment is, right? And then my physical exam is really looking at it first. I don't want to, make the child upset. So looking at the wound, looking at the arm, seeing if there's any deformity, ecchymosis, edema, lacerations, abrasions, open areas. Look for any kind of points of maximal tenderness, palpation. If I have, I do a lot of questions. Does it hurt here or here? A or B, B or C, which hurts the most? Really figure out where it hurts the most and get a sense. Is there a scaphoid injury? Is there just a radius injury? Is it a metaphysis, diaphysis? Physis, you can get all that with just exam, just by really being pinpoint and very specific, but also very gentle and slow. And then look for any kind of active passive motion if they have any. Obviously, with bad deformity like this, you're not going to really look for much. But when I see these wrist radiographs, wrist fractures, you want to get wrist radiographs. You don't want to take the forearm X-ray they got in the ER. You oftentimes want to look at the wrist radiographs to see exactly what the issues are. Is it, what's the inclination of the radius? What's the ulnar variance? What's the volar tilt, dorsal tilt, all those things. And if you have any complicated intra-articular injury, then advanced imaging is helpful, right? So a CT scan looking for different fragments, where they are, what's happening with them, it helps you decide surgery or not. And then for concerning things like occult injuries or ligament injuries, an MRI is helpful too, to see like what you can find and what you can see. So some of the things that we look for are, patients like this. She had, fallen off a jungle gym and had bilateral wrist pain. Obvious deformity on the left, had a displaced metaphyseal fracture with some physeal extension. The right wrist was called a buckle fracture. If you take a closer look at the X-rays, though, that fracture really goes into the physis, right? So this fracture line, I'm not sure if you can see my pointer here, but goes up to the physis. There's a fracture going to the physis. So it's really a physeal fracture. So minimally displaced Saltair's 2 fracture, nothing to worry about necessarily, except for the physis. And so these are the fracture lines that we're looking for. The left wrist healed greatly with X-rays every week, really healed just metaphyseal fracture. But the right side looked not so good, healed, but began having ulnar-sided wrist pain. And you can see here on the 6-month follow-up X-rays, the physis has really disappeared. And I think the ulna is also overgrowing now, where it was neutral alignment before. At 4 weeks, you could see. Now it's really overgrown and 2 to 3 millimeters too long. And now she's developing ulnar impaction syndrome. So we do an MRI to look at the physis. We see a pretty big physeal bar, but we also see that the thumb metacarpal on this view is basically done growing. So she doesn't have a ton of growth left. And that helps guide our treatment plan, because she doesn't have a ton of growth left at all. We would just do wrist arthroscopy with TFCC repair, because she had ulnar-sided wrist pain. She had a peripheral tear and was fixed with a couple of stitches, and then had a distal ulnar epiphysiodesis as well, just to help guide the treatment. I don't think she had enough ulnar impaction to do an ulnar shortening, but that's something we think about when we're treating these. Is it ulnar-sided pain, more TFCC, or is it central pain, which is more ulnar impaction into the lunate, and that's what causes the pain there. So even these benign-looking injuries, right? This was a buckle fracture, has definitely caused issues. Second case, more of a complex injury, so open physes. He was playing football, tackled somebody, someone fell on his arm, had a whole bunch of people land on it. Hit an open wound volarly, had dense numbness to the index, middle, and thumb. And these are the best X-rays we could get of his wrist. It's really out of place, right? The distal ulna is bad. The metaphysis is really dissociated from the diaphysis of the radius, and the TFCC has a little fracture there. So he was taken emergently to surgery, did an IND, washed it out really good. The wound was more ulnar than radial, which is what happens when the radius displaces, the wound is ulnar. Had a carpal tunnel release for the dense, acute traumatic carpal tunnel syndrome, and we stabilized the distal radius into the ulna. He was so swollen that we didn't want to do a plating of the distal ulna at that time. Just sort of pinned it together to kind of stabilize it, and then admitted him for observation, and go from there. So complicated fracture, needs a complicated treatment. He's 14. He doesn't have a ton of growth left. I don't mind necessarily putting screws across the physis, but I think in this case I was able to just barely keep the metaphyseal if we need to fix it later. Unfortunately, I have to go to the ASSH meeting, and the next day he develops compartment syndrome. So he was taken to the OR by my partners, had a few more washouts, and then when I came back, I had to close it. So he had a distal ulnar ORAF to kind of help stabilize the wound, to take the pins out. And then because of the previous incisions and open distal ulna, we had to put Integra and then skin grafts on top of it. So because he had median artery, median nerve and radial artery were exposed. And that was skin grafted, healed nicely at 3 months. Finished growing, took the plates out, and he showed up for another injury playing football 18 months later, but nothing going on, benign exam. But nicely healed, doing great. So things to think about with these high energy injuries, like what else can be injured? Not just the bone, but the nerves, the soft tissues, open injuries, DRUJ. All these things need to be looked at to make sure that we're taking care of these patients. So the third case we have is a female with a history of OI. She fell only had 3 fractures previously, so nothing bad, minor injuries, but definitely has this sort of volar subluxation of a volar Barton's fracture through the physis. Not too common to go through the physis with a fracture, but she certainly had a Salter-Harris 4 fracture. And mild deformity, no numbness, tingling, neurovascularly intact. She was reduced. We got sort of the wrist aligned a little bit in the reduction X-ray, as you can see here, but the volar Barton's piece is still volar and out. And then you can see that over time, this was followed by one of my partners and ended up subluxating volarly again, and the whole carpus was malaligned. And so she shows up, 4 weeks later with this sort of intra-articular malunited fracture through the styloid and through the volar Barton's fragment. So the lunate's sitting certainly in the bad spot and has limited mobility with about 4 millimeters articular step off. So these are complicated. These fracture patterns, the oblique volar Barton shearing fractures, can happen in kids, and those generally require plating to buttress it. I know in this case we had to do an articular osteotomy through the previous fracture plane, and when we were doing that, we ended up breaking the dorsal cortex too because of OI and all those issues. I don't like plating in OI, but sometimes you have to do that. So in this case, we put a narrow plate on, got the wrist lined up nicely, and then just going to go from there. So 6 months later, I take the hardware out. I don't want to leave hardware in for OI. It's just a stress riser, but looked good. She got good mobility back, good motion of the wrist, and good strength. And then 1 year out, doing great, and no concerns. And so one of the last cases we have is a 18-year-old football player. This is something we see typically where they have an injury 1 year, had a sprain during one of his training games. They taped him up for the year, hurt here and there, wasn't too bad, but never evaluated by ortho. It was seen by his trainer, and people were like, "Oh, it's probably fine. It's just a sprain." But he continued playing and didn't really talk about it much, except for the next year when he went back out for football. Training started lifting and started hurting. And so mom's radiology tech said, "Let's get an x-ray and come on in." So he certainly has this x-ray showing a very minor fracture looking at the proximal pole of the scaphoid. But we all know that scaphoid fractures are never really minor. So looking at the blood supply, we got an MRI to see what the blood supply looked like. And there's certainly a difference in the vascularity of the proximal pole and the distal pole. And that's because of the scaphoid blood supply coming from proximal and going out to distal, and mostly from that dorsal scaphoid branch coming in to the proximal pole, and the volar branch coming to the distal pole. So for our approach with this, I don't think a vascularized bone graft is necessary in acute scaphoid fractures. You get enough creeping substitution that if you drill across that, put some bone graft in the fracture, I put a screw to stabilize it, it can heal. And so that's what we did. Just a dorsal approach, took down the fracture, scraped out the non-union site, and bone grafted it with the distal radius bone graft, and then put a screw down. It healed really nicely after about 8 to 10 weeks, and he was out playing football again. So that's sort of my quick case-based approach. I know Tesco wanted us to do like 10 minutes talking, 10 minutes discussion. So happy to talk more about stuff. But I think the thing to think about with kids, you can get complex wrist fractures like adult type fractures because kids are doing more high energy injuries and still have the same type of bones. The ligaments are strong and the bone and face is often soft. And so that you can see more injuries to bones than you can with ligament injuries. And then you have to understand the risks, of these fractures and what to look for with these different fracture patterns. So, thank you from Cincinnati. Appreciate you guys listening in today, and I hope you guys learned something. Thank you.
Thank you, Kevin. We would love to listen your talk about in the future about TOS.
Yeah, happy to talk more about it. Something that found me, but I don't know why. But here we are.
Dan, would you mind to moderate this talk?
Sure. Let's do it. Thanks, Kevin.
Thanks,
that was great. I think there's So my take home points from your talk, right, is that intra-articular fractures and intraphyseal fractures requires a different level of care than extra-articular, extraphyseal fractures, which I think is really important to understand, right?
Correct. Yeah.
Yeah, and I think that one of the things that I don't know what your views are um, on taking care of Salter-Harris 1 type fractures that are slightly late presentation, or even 2s.
Mm-hmm.
When do you sort of give up? Like, when do you accept and leave it?
Yeah. So for like the displaced ones, right? Do we reduce or not? Right. That's a good question.
Correct. Correct.
Yeah, I think that the 7 to 10 days is a good point. Uh, you know, 7 is sort of like the earliest, 10 days at the latest if you're really worried about it. But there are times when I'll see somebody and I'll think, remodeling versus healing, right? So if you're 7 and you have a pretty badly displaced fracture and it's 10 days out, I think you have a lot of remodeling potential, and I've seen that happen where they remodel remarkably well in 6 months and they're back to normal again. And so the risk of physis arrest at 7 is way worse than the risk of physis arrest at 12 or 14.
Yeah,
So
I recently had an 11-year-old kid, girl actually.
Mhm.
So should be getting close to closure, right?
Mhm.
And and she was about 50% displaced, Salter-Harris 2, right? Completely remodeled by 6 months. You couldn't even see it. I was quite shocked
Yeah.
because so I think that I've seen this before. I've seen people try to push on Salter-Harris 2 fractures couple of weeks out because they feel that it's very displaced. And I think that that's a big problem. Physeal arrest is about the worst thing you can do to a child. And I think a little extra-articular osteotomy, which is what you'd have to do for a Salter-Harris 2 that looks bad, is not such a terrible thing to do to a child. But physeal arrest, if you cause it, I think that's really bad.
Yeah.
Right?
I tell that to families. Like, the worst thing we can do is make this breastplate stop, especially if you're young. If you're
Yeah.
like 14, about to be done, I look at the thumb metacarpal physis because that's a good indicator. Like, the thumb metacarpal generally closes about a year before the distal radius. So if your thumb metacarpal is closing or closed, you're at that, like plateau of growth, right? You grew really fast and then you kind of leveling off at cruising altitude. And so for those kids, I think, just being more aggressive is fine because they don't have a ton of growth left. But if they're younger than that open metacarpal physis, then we can count on some remodeling, and we definitely don't want to damage the physis. So
Yeah, I agree. Let's see what we have in the question bank here.
yeah.
For which age do you recommend plate or K-wire fixation? Do you have an age, or do you have,
I think it's
or
worth.
more importantly, do you have an indication for fracture types and age,
Yeah.
or along those lines, right?
Yeah, so for the most part, I will do K-wires for distal radius fractures if I can. But in older kids generally, and it really is just because of injury patterns, right? So those Barton type fractures, where you have volar or dorsal Barton fractures, you need a buttress plate to stabilize it. It's really hard to put K-wires into buttress a fracture like that, an oblique fracture. So those are the fractures I will fix with plates, or really complicated bad ones, or ones that are near malunion where you have to plate to stabilize it. But younger kids with metaphyseal fractures, pins all day long if you need to pin it. But those, articular ones, and you know, that's sort of like my thought. It's more fracture pattern, and I have to say I probably put in dorsal plates about as much as I do volar plates. I think that's driven by injury patterns. It's not just a volar plate for everything. It's a dorsal plate when you have a dorsal fragment, and it's a volar plate when you have a volar fragment, if that makes sense.
That's interesting. And from a technical standpoint, because I am like a never dorsal plater unless I absolutely have to. What any technical pearls on avoiding tendon injury, location? I saw the type of plate you used, which looks like a giant hunk of metal. So that covers basically the entire dorsal surface of the radius. So any suggestions on type of plate,
Yeah.
dissection
So I like
points?
the lower profile fragment specific type of plate.
Mhm.
So, I mean, I generally will try and use TriMed, no, no conflict of interest, but they have really good low profile plates for those fractures. Synthes has some smaller plates too that have, different varieties of things you can use. So I use those sort of lower profile ones. If you have a big piece, I might use a big dorsal plate. That kind of covers it. But in general, because of the tendon issues, I will take those out between 6 to 9 months because of the tendon issues that will happen. And you almost always feel some crepitus over those tendons, over the plates. So, volar plates, less likely to take out. Kids with OI, always take them out. Kids who are irritated by the plate or don't like it, sometimes it doesn't, fit quite right. And that volar distal radius, you can kind of feel. So those are the ones I will, I will take out the plates. But yeah, in general, dorsal plates always come out, volar plates don't. So that's my
Do you
patient.
often find when you take before you take out the dorsal plate, how frequently do you find that patients are having sort of tendon irritation symptoms, not just crepitus, but like they hurt? Or is
Not
that
often, but I don't want it to get there. I think by the time it's starting to hurt, you're really damaging the tendons. So
yeah, that's what I wanted to ask.
yeah.
Exactly. So I think you're prophylactically removing it, and by the time you get there at the 6 to 9 month period, you're already seeing some tendon involvement.
Right. It's
So
irritating, but not painful yet, but it will probably get there. It's gonna keep snapping and grinding.
right. Okay. And then do you have a preference? I think the TriMed is titanium. Do you have a preference, titanium versus stainless? You
I
care?
don't. I generally use titanium just because the very variable axial screws, right? But it just depends. Like I
Mhm.
don't think it matters that much, honestly. Just
Yeah.
whatever plate fits. I think Stryker has a lot of very, narrow plates that will fit in kids. TriMed the same way. Like TriMed has good, narrow plates, but they're more stainless steel. Honestly, they're not for me anyway. They're not titanium. So
Yeah, I also don't really have an age cutoff. For me, it's fracture pattern dependent. I'll try pins at whatever age I think I can get away with pins, and I'll do plates whenever I can't get away with it, right? Something like that.
yeah.
And then the other point I think for plating on the volar side is that, and we've done this, so we're guilty, right? As Roger says, ask me how I know, right? When you plate using a kind of distal radius-y or some kind of T plate or L plate, and you plate a young child for a volar Barton's type fracture, right? We're using as a buttress. By the time that kid is grown, that will be in the middle of their forearm, and it'll look absolutely ridiculous because the wings will stick out into soft tissue. So I think we've gone to whenever we can on the volar surface using a straight plate, and we find that you have to take those out a lot less. So I don't know if you have that experience as well.
Yeah, I think, yeah, I just, for the ones that I'm putting the distal radius plates, it's because they have metaphyseal that sort of stuff, comminution. So you have to use that wideness to kind of help stabilize everything. If it was just a Barton's fracture, I think that's reasonable to do. Actually, for a lot of the Barton's fractures, I won't put anything in the epiphysis or the fragment. I'll just buttress on the diaphysis and then use the plate to stabilize it. I don't have to put any screws through the fragment.
Yeah,
So
I
that way
totally,
I worry about the
completely agree.
physis, but then maybe I don't need to use a whole distal radius plate for that, but I do. So
Yeah, absolutely. We don't, we do the exact same thing. And then if you are seeing, um, when do you do an ulnar epiphysiodesis? Or do you?
I don't at the initial visit, and I've been surprised sometimes. I've had a few kids that have fallen like 2 stories, and they have these blown apart metaphysis where there's like pieces of metaphysis like in the carpal tunnel, and you put
Mhm.
it back, and I plate it, and I'm like, there's no way this is gonna grow, but they've grown, and so I can't predict who's gonna have a growth arrest. If I'm gonna put screws across the physis and they have a lot of growth left, then yeah, I would do that. But for the most part, I can angle my screws, to avoid the physis with this variable angle plates. So I don't do that, and I just watch and see. Because I've actually been shocked at some of the things that have grown when I would not expect them to grow. So I can't be 100% predictive, and I don't want to, stop the distal ulna and then have the distal radius grow, and all of a sudden you have an ulnar negative variance and some other, you know, MHE type of forearm happening.
Mhm.
So.
Yeah. And how long do you follow these Salter-Harris fractures, to confirm that they're still growing? Do you do the Roger thing of waiting 2 years, or do you
I
6 months,
don't.
a year?
Yeah, I mean, I want to see positive growth. I haven't had anyone, bite me that, had a growth at 6 months that stopped growing at 2 years, when the rest of the wrist was growing until 4 years out or something. I haven't seen that. I think if you see a sick physis that looks a little weird, then I would follow it. But if you see normal growth and it looks great, then I stop at around 6 to 9 months if I have documented normal growth. So,
Yeah.
but I don't follow them forever. I don't think that's helpful. I've had a few cases where you have a growth arrest of like 5%, and it leaves like a little, I don't know, like a shaft, like just grows. The physis is growing over that growth arrest, but there's like a little tube that you follow in the metaphysis. And I'm like, is that going to end up stopping early? I don't know. So I keep following those just to find out. But those are the only ones I've seen. Like you have a documented very minor partial growth arrest. So.
Yeah. Do you have a sense of, um, how do you treat central, peripheral physeal arrests, and do you bother? I mean, our success in treating physeal arrests is pretty poor.
Mm-hmm.
I don't know if you have better experience or any tricks or tips, because I'm sure if you're seeing this many fractures, you're seeing some arrests.
Yeah, I mean, for the most part, I'm just doing a completion epiphysiodesis. If
Yeah.
you're under 10, I might consider, a physeal bar excision. I've done one peripheral bar that worked really well. I took some, it was like a volar peripheral bar, and I took some tenosynovium from the tendons and stuck it in there as like a fat graft, and she grew great after that. So and she like was growing like into like more volar tilt, and she grew herself back to straight again. So
Mm.
I have not taken out a central bar with success yet. Don't know if
Me
it's
neither.
possible.
Yeah, I've had one that, like, my experience with central bars is they kind of grow and then they stop pretty quickly. But you
Yeah.
do get a little bit, it's like, yeah.
Mhm. Yeah. So I do wonder, and something that Roger was looking at with MRI is that you might be able to see that there's a growth arrest, but there's also an area of sick physis around it where it's not normal. So we take out the growth arrest, but the sick physis is still there, so it still tethers the growth. Um, so I don't know. I just saw a kid recently that they asked me to look at. I haven't seen yet, but like it looks like there's a 25 to 30% physeal bar centrally. I'm like, oof, like got a lot of growth left. Can I try and fix that? I don't know. That seems like too much. So, but
Yeah,
I
yeah,
think
yeah.
like 5% or less will grow. 50% and more you can never fix. But I don't know about that like 5 to 50%. Is it gonna help or not? I don't know. I don't have a good
Right.
answer. It's not worked for me.
Do you have any other, let's see, any other questions? Chesko, do you see anything? I didn't
No,
see
no more
anything else.
questions.
Okay. And then any final thoughts, Kevin?
No, I think, yeah, just look for interesting fracture patterns because you'll see them in kids. ligaments are stronger than bones, and you'll see random weird fractures in kids because they're trying to do something that adult type injury, but their ligaments are stronger and they'll avulse pieces of bone. So just look for those.
I would say my take home point based on what you were saying and my experience is that do not believe the buccal fracture always. So I've seen a bunch of those buccal fractures be Salter-Harris 2 fractures.
Yeah.
So I think you really do need to be cautious and make sure that even though it kind of looks like a buccal fracture, make sure you follow out that fracture line because you will get burned.
I think, I call that a buccal Harris 2 fracture when I teach the residents. Like, because it looks like a buckle, and the Thurston-Holland fragment is a buccal fracture, but it's really a Salter-Harris 2. So I treat it like a Salter-Harris 2. And then, I cast almost all the Salter-Harris 2 fractures just because I think, the risk of a second injury is way worse than the first injury, and then follow them out for a while and make sure that you don't have growth problems. So.
All right. Well, thank you, Kevin. That was wonderful.
Thank you.
Chesko, you want to take over?
Thank you, Kevin.